Good morning, everyone. This is Tu, one of the second-year internal medicine residents at Memorial Healthcare System in South Florida. I'm excited to present this case today of a Pheochromocytoma presenting as acute congestive heart failure. Our patient was a 38-year female with a past medical history of poorly controlled hypertension and type 2 diabetes. She presented to the emergency department with palpitations, dyspnea, and signs of volume overload, as well as imaging and labs suggestive of CHF. All the infected workup was negative. The initial echo showed an EF for 25% with multiple segmental abnormalities and global LV hypokinesis. She was started on diuretics, vasodilators, as well as GDMT as far as her blood pressure could tolerate. Cardiac catheterization ruled out atherosclerotic disease, but it did comment on highly elevated filling pressures. She received an inpatient cardiac MRI, which showed an EF of 32% with global hypokinesis and eccentric hypertrophy, favoring tachycardia-induced cardiomyopathy over hypertensive cardiomyopathy, which would have presented as a concentric LVH pattern. Despite aggressive diuretics for 4 days, or the meanwhile, where she had good urine output, she developed acute worsening of her respiratory status on day 4. Rapid chest X-ray was concerning for possibility of flash pulmonary edema. She also continued to have tachycardia and poorly controlled left blood pressure while being on 3 antihypertensives. Evaluation for secondary causes of refractory hypertension revealed elevated urine and serum metanephrines and norepinephrines as well as DMA. Interestingly, the ratio of metanephrines to norepinephrine was less than 1, which favored paragangliomas as the cause as per literature reviewed. We did an adrenal CT. It showed a 3.8 cm right adrenal nodule favoring Pheochromocytoma. However, there was uncertainty regarding this category image search only coming from the adrenal nodule, most likely a Pheochromocytoma or presence of paraganglioma as well, or both. We started alpha blocking with doxazosine. Carvedilol was weaned off and limited GDMT with anastrozole, and spironolactone was continued. After 7 days of alpha blocking, we restarted her carvedilol at low doses and titrated it up. Due to the uncertainty of diagnosis, we thought it is best for her to get medically optimized outpatient as well as get a PET CT just to make sure that there was no paraganglioma involved. She did receive an outpatient CT which confirmed only isolated uptake in the adrenal mass without any additional kind of uptake. Patient underwent successful laparoscopic right adrenalectomy. She was seen as an outpatient basis 3 months after the procedure, where she had great control of her blood pressure while being only on 1 antihypertensive, which was anastrozole as per her GDMT. In conclusion, we described an unusual case of critical immune secreting tumor presented as frank CHF. There have been some studies in a retrospective analysis of 36 patients. The others described only 3 patients who presented with overt left ventricular failure. However, the timeline was not really clear in this study as to whether this was in presentation or afterwards. The tricky part in this situation is identifying the source, especially if radiologic evidence and lab findings are not really aligning, as well as ensuring adequate alpha blockade with simultaneous maximized up titration of GDMT, each representing unique challenges. Thank you very much for your time. Good morning.